consented for transplant, and we've evaluated the donor to make sure it's a good donor. Then they run a match run, and that basically the computer then spits out a list. Some of the things around matching include size, so a heart has to sort of be fairly close in size to the person that's getting it, not exact. As I said, there's some antibody issues that can occur sometimes, so certain hearts may not be a good match for somebody because you've already been exposed to things that might make you more likely to reject that heart. We take that into account. So the computer spits out that list, and then we basically, go by the list essentially. We sort of, whoever's the top person on our list gets offered the heart, and if everything works out, we go ahead and do that transplant. So it's really kind of controlled by this computer system more so than anything else, which is good because I think it maintains, integrity. It makes sure that, if you're listed here, somebody else in another program isn't trying to take over the system. And so it's less important for us because we're the only adult heart transplant program in Mid-America Transplants service area. But you can imagine if you go to the city of Philadelphia, there's 5 transplant programs in the city, and so they've all got people listed. And so it really has to be a way to kind of make sure that heart is allocated to the right person in a fair and equitable way. And then the criteria comes up a lot by how people are listed when they're waiting, and so it's really broken down, what I say, into kind of 2 lists essentially: status 1 and status 2. Status 1 patients these days are defined as somebody who has a VAD or somebody who's getting continuous infusion of a support medicine like dobutamine or milrinone. And then there are sort of some caveats along with that. So if you've got a balloon pump or some other, mechanical device, you're on a ventilator, those kinds of things, that increases that level to 1A. And then like a stable VAD patient or somebody walking around with milrinone in is a 1B. Most of our patients are status 1B, and there's probably a handful that are 1A at a given time. What's happened over time, with mechanical support and having VAD patients listed and kind of those patients being a little bit more stable, is that we almost do no status 2 transplants anymore. 15 years ago, we would call somebody in from home who was not on any of these therapies and do a transplant. But unless you have an unusual blood type like AB, or you're a really small person, that could take a donor that might not match for somebody else, I think last year, all of our transplants were status 1. And so, it kind of not complicates, but it makes the wait list a little bit different. And, some people are on the wait list as a status 2, but that time on the wait list really doesn't mean a whole lot. Unfortunately, it's not like you add up status 2 time and then you add your status 1 on top. It's all in the same category. So if you've been status 2 for 3 years and all of a sudden you get a VAD, you kind of start from ground zero again in that status 1 bucket. There are thoughts around how we may want to change the way we allocate thoracic organs. And so the Thoracic Organ Committee at UNOS is kind of looking into this because VADs have changed. A lot of those people who are waiting at home are pretty stable. They may not be even quite as sick as somebody who just came into the hospital or somebody who's on inotropes. So that's all being considered, but I think those changes being actually implemented and happening are still probably at least a few years away before we would change this scheme at all. And this is even kind of not up for grabs, I would say, but even the way the country sort of divided up into these donor service areas may change over time. And so when they first came up with sort of the organ procurement organizations, they divided the U.S. into these donor service areas that roughly at that time tried to kind of make sure that most of the organ procurement groups had similar numbers of donor hospitals within that area. But as you can imagine, over the 20 to 30 years we've been doing this, some hospitals now are busier than others, and the number of donors in a given area have changed over time. We're in actually donor service area 49, so you can see it kind of includes some of Missouri, not all. it actually is broken up. So Mercy Hospital, the Springfield hospitals are included, and Jonesboro, Arkansas is included. So they kind of made this weird donor service area. So it doesn't even include all of Missouri. Midwest Organ Bank, number 50, actually includes a big chunk of Missouri, even over, past Columbia. And so it's a little bit of an odd map and the way it works out. And some of the organ procurement groups like Mid-America Transplant are really high performers. They really do a fantastic job of what they do. So you can imagine that you might actually want somebody like Mid-America Transplant to control more of this because they do such a good job, where some of these other OPOs maybe don't do as good a job of getting referrals, getting people to donate, turning them into good donors. And so this process may even change over time a little bit, but you can imagine that's kind of why it's a little bit complicated. And then, so about 6 or 7 years ago, the system changed. So it used to be when a lot of you got transplanted, we would have a list and we would go through the status 1 patients, and then we go down. If we didn't have any status 1 patients that could fit with that organ, we'd go down to status 2. And now that's changed. And so now it goes to status 1A or 1B in our area. And if I don't have somebody that's status 1 that matches that heart, for instance, then it can be offered to zone A, which is that pink circle essentially. So any status 1 patient in that pink circle can get that heart. And so that's why we don't do any status 2 transplants anymore. Because if it's a good heart and it just didn't match one of my recipients for size or something, somebody else is going to end up matching with that and taking that. It's rarely going to come back to us for a status 2 recipient. So that whole process, and it was designed to basically try to transplant the sickest patients, the people waiting first, and then take the people that were more stable. And I think it's accomplished that, but if you're a status 2 recipient kind of sitting on the wait list, it makes your wait time even much longer, and it almost necessitates you have to get sicker before you actually get transplanted. So this is the numbers. I just want to show the numbers around the mechanical heart program, and you can see that in about 2009, 2010, this is when the HeartMate 2 got approval for bridge to transplant indication. And so we finally had a good device that would actually support patients in an ambulatory way that had as low a complication rate as possible. And so that's when the implants of VAD started to increase. The red is patients who are getting the VAD as a bridge to transplant. The blue bars are patients who are getting the VAD who have some problem that they can't be transplanted right now. Maybe never. Sometimes it may be somebody who's maybe a little bit older and can't be transplanted. Maybe it's somebody who has other medical problems that the anti-rejection drugs would be a really bad idea for. So we can actually implant this as what we call destination therapy. It's basically a long-term treatment for heart failure. And so that number has gone up as well in both categories. In 2013, we did 122 VADs. Last year, we did 108. And I think we'll continue to be a 100 to 125 a year VAD program, just depending on which patients come in. And I think the newer devices, as I'll show you in a minute, are actually going to probably expand mechanical support to even more patients as we go forward. So I want to just highlight a couple of things. I think I maybe showed this once before, but this CardioMEMS device you might read about in the newspaper just got approved by the FDA for managing or actually following heart failure patients. It's a neat device. We're trying to get the hospital to acquire it so we can start using it. But this, you can see in panel A, it's a very small little sensor. Those two little wire loops on the end really compressed down so it can actually go up through a catheter, just like a catheter in your leg when you get a heart catheterization. And so that thing goes up, we put it out into one of the veins out in the lung, and we pass that sensor out there, and we leave it in the pulmonary artery, one of the distal pulmonary arteries. And then when you're at home, you lay down once in a while on this mat that corrects for barometric pressure, And this thing will basically take a waveform of your pulmonary artery pressures. And it doesn't show very well. You can sort of see, see the person looking at the computer screen, kind of looking at the pulmonary artery pressures. And this device was studied basically in patients with heart failure, and this is what the readout looks like. And you can see this person started on the left with fairly high pressures, 50 millimeters of mercury systolic, and with increases in medication over time, the pressures came down very nicely into the range that was designed, to not trigger the alarms. And you can see you can kind of get a beat-to-beat measurement. This is just like we would get in the cath lab if we had a catheter in the pulmonary artery. So it basically allows us to both look at whether somebody needs more medication for their heart failure. It can allow maybe for an alert to say, hey, this person's doing worse for some reason. You need to get a hold of them or see them in clinic or add some additional medication. So hopefully, and what the trial actually showed is that hospitalizations or rehospitalizations for heart failure actually went down in people who got this device. And so we're going to actually hopefully start implanting this. We were in the trial that proved the device was effective, but it's been a little while. So we're going to try to start using this device again for people who are having more heart failure. So the trial that proved it, 550 patients, they all underwent the sensor. And then some people got treatment group where I could look at their data and change their medicines. And then some people were in the control group for 6 months. And then at the end of 6 months, the number of heart failure hospitalizations actually went down in the people that had the device. And interestingly, I think 2 of our patients who got this device had it while they had heart failure. They got a VAD and had it while they had a VAD for a while. And then they had it after they got their transplant. So we've got a couple of people that still have a device. It stays there forever. And you can see here that the treatment group, the red line over here at the left, is the number of hospitalizations. And so they had much fewer hospitalizations over about a 2-year period, whereas the blue line kind of keeps going up. The red line seems to level off and get better. So, I think we're encouraged by that. It's certainly not, it doesn't treat the heart failure in any way, but it really allows us to really closely monitor people. And just like everything else, somebody's always watching you now with your, what's going on in your cell phone, what's going on in your lung. We can watch everybody from what's going on in your defibrillator, so we can monitor people remotely. A lot of people have been asking me about this drug, this LCZ696. It doesn't have a name yet. It's still a compound. And it was just published a few months ago, or maybe about 6 months ago, in the New England Journal. It's really a new class of medications for heart failure. So we haven't really had any kind of new medications come around in some period of time. I don't think it's going to be a dramatic, it's certainly not going to cure heart failure. But what this trial looked at, so LCZ696 is what's called a neprilysin inhibitor. So a lot of the good things that your body makes to help when you have heart failure, neprilysin is actually the enzyme that kind of chews it up and gets rid of it. And so this basically inhibits that from happening, and so hopefully your body makes some good things that helps you when you have heart failure and they stick around longer. So it's a neprilysin inhibitor plus a drug called valsartan that we already know works for heart failure. It's a Novartis compound, and that's their heart failure drug. And so they compared it to enalapril, which is an ACE inhibitor that everybody is, a lot of people take lisinopril or enalapril or one of the ACE inhibitors. So they compared LC696 to enalapril in people with mild to moderate heart failure. The trial was actually stopped after 50 months of follow-up because it looked like the LCZ696 group was doing so well. And the primary endpoint was heart failure-related hospitalizations during a 6-month follow-up period. And so this is kind of a busy number of slides I pulled graphs I pulled from the New England Journal, but basically LCZ696 is in the red bar. So if you look at the primary endpoint of hospitalizations, if you look at panel B, which is death from cardiovascular causes, C is hospitalization for heart failure, D is death from any cause. Everything was better in the LCZ696 group. This is a large number of patients, and so even though the bars don't look like they're that far apart, it's a pretty significant finding. And so this drug I expect to be approved by the FDA sometime later this year. And so it may be, you know, a treatment for some people with heart failure that aren't getting the benefit that they should, you know, they feel she should get from things like valsartan alone or enalapril. It's now being studied as well in people who have a strong ventricle that squeezes okay, but it doesn't relax okay, or what's called diastolic heart failure. And so that trial's ongoing right now in our place. I think I've shown this before, but one of the other device things that's going on is trying to change so when you get heart failure, your autonomic nervous system gets really revved up, and things like adrenaline and other things in your body affect your heart. And so the vagus nerve is very important in that regard. And so there's a lot of work going on to try to inhibit what goes on in the vagus nerve. And there's actually some devices that are kind of like defibrillators, but they actually hook up to the vagus nerve and stimulate the vagus nerve to decrease the sympathetic drive that you have when you have heart failure. And so there's actually been some pretty interesting preliminary data. So it's kind of like, you know, the sympathetic nervous system is the accelerator. We block it with drugs like beta blockers and other things, but what we also need is sort of the brake on the sympathetic nervous system, and that's what this vagal nerve stimulator does. And so we're in the middle of a trial looking at that. This CardioFit device, which you see, it looks a lot like a defibrillator. That little white sort of sleeve on the end goes around the nerve. Dr. Sanchez, one of the vascular surgeons, puts that on with this very small incision, and then it has a wire that goes down in the heart to monitor the heart rhythm and then stimulates the vagus nerve. And you can see here the patient that got the stimulator could walk farther in 6 minutes, one of the standard tests we do for heart failure patients. And if you look at their quality of life scores, they got better as well. So there seems to be some preliminary data that this works. And it may even actually make ejection fraction go up. So very much like a beta blocker does as well, vagal nerve stimulation might make the heart actually improve its function a bit. So that trial is still ongoing. So what's new in heart transplant? Heart transplant stuff kind of changes kind of slowly. You know, I mean, a lot of the drugs are still the same. As you guys know, many of the drugs are now generic anti-rejection drugs. I've shown this before, but this is basically a lot of you are now on sort of an AlloMap strategy. When we used to, so sort of the more senior group in the audience used to get a lot more heart biopsies than we do now, mainly because we have this blood test available. I was just asked at dinner if you need a heart biopsy 10 years out. Not really. So we do most of our biopsies now in the first 6 or 8 months, and then for people that are doing well, we transition over to getting this blood test, which basically looks at some of the genes that get turned on or get regulated up when you get rejection. And if that number looks good, your echo looks okay, and you feel okay, the chances that you have rejection are probably less than 1%. And so this trial kind of proved that, and basically this image trial, and this is complicated, but basically what we're looking at is this what's called gene expression profile. This test is still proprietary. It's still done out in California, so we have to take the blood at a special lab here. We have a lab at the CAM, and we have a lab at the HCI, or at HCI complex. We get the blood, we process it right there on the site, and then we send it to California, and they do a quick turnaround on that. They give us what's called a gene expression profile score. And if it's less than 34, again, the chance you have rejection is very, very low, and then we forego a biopsy in that visit. If it's more than 34 and it's a new finding, then we might go ahead and do a heart biopsy just to confirm it. And so you can see here that the AlloMap group and the non-AlloMap group, or the biopsy group, the red line and the black line are essentially on top of each other for the whole follow-up period, showing that the two strategies are basically equal. So I think you're going to see more and more of that. There really aren't a lot of new medications out there for transplantation. Someone asked me at dinner about donation after cardiac death. I've seen a couple of reports. The other solid organs like kidney and liver, sometimes when the donor's not technically brain dead, not technically doesn't meet all the criteria, but essentially has no chance of recovery. The donor family may choose to go ahead and do donation, and what they do what's called donation after cardiac death. They stop life support, and they essentially wait for the heart to stop. That's sort of the criteria they used to use for donation many years ago, and then they take organs at that time. It puts a little more strain on the heart to allow it to, you know, stop completely and then have that warm ischemic time. So I think it's something that you'll see more and more examined. There are a couple of machines. Mid-America Transplant has a lung machine, a perfusion machine. At one point we were demoing or thinking about getting a heart perfusion machine where basically the organ can be taken, it can be hooked up to a pump and circulated with the donor's own blood and actually give that heart 6 to 8 to 10 hours of time to see if it's going to recover and get stronger before we would decide on transplantation. So those things are sort of in the realm of what might happen over time, but not quite there yet. Mechanical support, you know, it continues to evolve. These are just the numbers again in another way, but you know, the destination therapy in green, bridge, and then the blue line is the total VAD volume. The HeartMate 2 is still, you know, kind of the, you know, one of the workhorse pumps. It's been around now, as I said, approved by the FDA since 2010. And it's approved both for the bridge to transplant indication and the long-term treatment indication. It's a rotor inside this electromagnetic housing. You can see here that the pink stuff is the electromagnets, and it spins this rotor at about 9,000 RPM, takes blood out of the main pumping chamber of the left ventricle and pumps it out to the body. As you know, I think there have been some, you know, bad patients at the meeting, you know, wear a battery pack and some controller, and really it becomes a, you know, kind of a second nature. I think a lot of people acclimate